Okay, well, good afternoon, everybody, and welcome back to our long COVID meeting with the Physiological Society. Thank you to all of the speakers from this morning's sessions. I had a really fascinating morning, and please do keep your questions coming in. I know we've got an audience from all over the world joining us. Please do post them in the Q&As for the individual speakers. If we can't get to your question, we do have a Padlet live. The link should be in your in the email that was sent to you all with the meeting link. So do please put your questions in there if they're not answered, and we'll look at them over the course of the meeting, relay them onto the speakers. I can see lots of great contributions in there already. So my name's Andrew Murray. I'm a metabolic physiologist from the University of Cambridge, and I'm one of the theme leads for the Physiological Society. And it's my very great pleasure to chair this afternoon's session on risk factors. Why do some people get long COVID and not others? So we've got three speakers lined up, but we haven't yet been joined by Danny Altman, who can hopefully join us in the course of the session. So we're going to change the running order ever so slightly. And it's my pleasure to introduce our first speaker, Elizabeth Ford. Thank you, Elizabeth, for stepping up early. Elizabeth is from the University of Sussex, and she's going to be speaking on risk factors and symptom clusters for long COVID, a retrospective cohort study using data from the COVID symptom tracker app. Thank you, Elizabeth.
Thank you. Hi, everybody. It's a great pleasure to be here. So my name's Elizabeth Ford, and I'm a senior lecturer in primary care research from Brighton and Sussex Medical School. I'm going to present the findings from my study, which was run with data scientists at the University of Sussex. So our study used data from an app, which some of you may be familiar with. It's the Zoe COVID Symptom Study app, which was set up by a team at King's College London and the app developer Zoe at the very beginning of the pandemic. So I think it was launched in the last week of March in 2020 and has had over 4 million downloads so far, encouraging people to contribute in real time their data about their COVID symptoms or any ill health, as well as putting in test results, vaccinations, and all sorts of other data about COVID. So for those of you who aren't familiar with it, you download the app onto your phone and you can report every day. Generally, the app will send you a notification to remind you to report. You press the button, report today, and it will ask you about any new COVID tests plus their results, and it will ask you how you're currently feeling. So whether you feel physically normal or not quite right. And if you say you're not feeling quite right, it will take you through a list of symptoms. And this has expanded over time as our understanding of COVID has grown. So there's quite a long list of symptoms, and you can tick whether you have any of them or not, and also how severe they are, depending on the type of symptom. So for example, with headaches, you can say it's all day or some of the time. And then, of course, this generates a huge amount of data that comes out the back end that we can use for research. So Tim Spector at King's College London has been leading his team there to produce a lot of high quality analyses on this data, which has been hugely helpful for tracking the course of the pandemic. But additionally, they made this data available in something called the SAIL data bank, which is hosted in Swansea. And they made that available to anybody who was doing research to respond to the NHS response to the pandemic. And through that mechanism, we at the University of Sussex were allowed access to the data and carried out our analyses. So what we wanted to do was to look at long COVID, because we felt people could contribute information on their symptoms long beyond the end of, say, the first 10-day or 2-week period of having COVID. And by capturing people who had reported symptoms that were ongoing for a long period, we would be able to look at long COVID, and using the different medical history and personal details they put into the app, we'd be able to start looking at risk factors for the illness. But this was obviously quite challenging from a data analytics point of view. We had to identify participants who logged regularly and who had logged many times, who had tested positive for COVID, and that who had logged their baseline health status prior to having COVID. They'd logged about their symptoms during their COVID illness, the initial acute phase of the illness, and who had continued to log regularly in the phase we looked at 12 to 16 weeks after COVID. So you can imagine applying these different criteria to the data meant that we had a huge drop off in terms of participants. From the 4 million people who downloaded it, we identified just over 4,000 who met all of these criteria. We also applied some sort of data quality criteria that they had to have a body mass index between 15 and 55. So it was sort of within what we thought was a range that was plausible and to be an adult. So when we were looking at our sample, we were very aware that we had highly selected people, and therefore we might have a biased sample, especially as this was app data. So it relied on people having the technology and the time to respond to the app every day. So it turned out that we had a slightly older sample with less ethnic diversity than the whole reporting population and the population of England or the UK as a whole. Our sample had around 60% women. It had a higher than average index of multiple deprivation, which was based on the postcode of the residents where people said they were logging from. We also linked through the SaIL databank index of multiple deprivation to the postcode, as just mentioned, and also air quality factors. So we could look at them as a causal factor for long COVID. So you can see here we had slightly older and a highly white sample. Then we needed to develop a definition of long COVID in the data because, of course, what we were doing was looking at symptoms logged each day. We didn't have a kind of clinical diagnosis. So we defined long COVID as having a statistically greater portion of negative health status in the period 12 to 15 weeks after the positive COVID test, compared to the period 2 to 12 weeks before the COVID test. So we had that baseline data. And then what we looked at in this graph, you can see a kind of each line represents a daily stack of symptoms. So basically, a portion of each bar that comes up vertically is a symptom. So the more symptoms that somebody indicates, the higher their line is going to be. So on average, our long COVID sample was still highly symptomatic, and that appeared to decrease slightly after their acute phase, but not drop back to zero. Whereas our recovered group, you can see they have symptoms, fewer in fact, symptoms in the acute phase of the illness, and then that drops roughly back to zero in comparison to what their symptom profile was before their illness. So then having our two groups, one with long COVID and one without, we started looking at individual risk factors for long COVID. And we looked at these in a split of different age groups and then across all participants and by men and women. So being female was one of the strongest risk factors for having long COVID. And following that was medical history. And this was defined as things like having an illness which limited activity and having a higher score of symptoms reported before the positive COVID test. Additionally, a strong risk factor was higher levels of symptoms in the initial illness. And this was quite predictive. So having a severer acute phase of the COVID illness was substantially related to having long COVID. There are also some weak associations with body mass index and age. And when we separated out these analyses by age group, the associations looked very different in people over 70 years of age, where diabetes became a risk factor. There was a positive association in that group with being male rather than female. But we do note that this was only 482 patients in total, including the long COVID and the recovered group. So it was quite a small sample in that age group. So when we were looking at symptoms in the acute phase of the illness, trying to understand which were most related, in fact, the sheer number of symptoms was the most highly predictive factor, and general health status of the individual before the illness. But then in terms of symptoms of COVID, fatigue, loss of smell and altered smell, especially remaining after 4 weeks, and self-reported brain fog were the most important factors. I've put this little graph in which shows the coefficients of each symptom, and I'll make sure the slides can be circulated so you can expand that and have a look at it later if that's of interest. So what we wanted to do was to combine the different risk factors that we'd identified in a combined predictive model, which ideally, if it was predictive enough, would be able to give clinicians an idea of how much at risk an individual would be of long COVID given an acute COVID infection. So we put all of the risk factors in a logistic regression model and applied a kind of predictor selection criteria called a lasso, which retains the most predictive variables. We found gender, the symptom score in the first 2 weeks, and the baseline health status, as well as this variable of having a condition which limited somebody's activity, were the most predictive. And then, not be interesting to discuss this, but also these different elements of taking vitamins seem to be predictive as well. And overall, our model had an accuracy of 77%. And there you can see on the slide, the strongest features were being female, this physical activity limitation condition, and the symptom level in the first 2 weeks of illness. And when we added in later symptom levels, still having symptoms at 6 to 8 weeks of illness was predictive of long COVID at 12 to 16 weeks. And that was obviously evident when you could see that graph of the symptoms just plateauing and not recovering. But one of the weaknesses that we identified in the model was that it was very poor then at predicting long COVID in patients who had no initial symptoms. So the best tuned model could only predict 5 out of 21 of the asymptomatic initial infection long COVID cases correctly. So that's something to be mindful of. The next approach we took was that we wondered whether there were different subtypes of long COVID, and this was something that was discussed earlier on because patients seem to have sort of different clusters of symptoms. So we tried a clustering approach on the data from the app using the 11 most common symptoms. And different clustering methods work in different ways. So we tried a range of these with the idea that if we could have several methods of clustering produce similar results, we would have therefore some reliable or robust evidence for those underlying subtypes. So we applied 3 methods. One's called K-modes clustering. Another is called hierarchical agglomerative clustering analysis, which I won't attempt to pronounce many times, and I'll call HAC, and also factor analysis. So when we applied these to the 11 most common symptoms, K-modes analysis didn't produce any obvious clusters. So that was the first result. Now, HAC produced 2 clusters. You can see these as kind of the heat map on the middle picture there, the blue picture. So where a symptom is loading highly onto a cluster, it's darker, and where it's not really loading onto a cluster, it's lighter. And so we felt that really the result out of the HAC analysis was showing 2 clusters, which we termed mild and severe long COVID. The factor analysis produced 4 factors, which explained 45% of the variance in the data. And looking at the heat map there on the right-hand side, we termed the first cluster as indicating fatigue and brain fog. The second cluster was more about joint and muscle pain. The third cluster was more about chest pain, shortness of breath, and irregular heartbeat. And then the fourth factor was rather difficult to interpret, but when looking at men and women separately, seemed to be about loss of smell or change in smell. So to conclude, we were able to find evidence supporting risk factors for long COVID, which have subsequently been established in other studies. We created a combined model which could predict long COVID in symptomatic patients with around 77% accuracy. And we did find some evidence of subclusters for long COVID, but these weren't robust or reliable across different methods of clustering. And we do need to acknowledge some limitations, which are that our sample is likely not representative of the whole population. As we saw, we had to highly select patients who'd logged very regularly. There may also have been attrition in logging by the long COVID population because it's rather dispiriting to log in and report the same symptoms again and again for weeks on end. Several potential risk factors were not measured in the app, so we didn't have data on those, and we would have liked to have been able to add more risk factors. And then it should be noted that these data were collected before the vaccine was rolled out. So we looked at logging in August to December in 2020. So post-vaccine long COVID looks potentially different. The newest evidence is that people who are vaccinated have a lower risk of long COVID, but it's not clear if risk factors are different in that group. We also have nothing on children because we selected only adults from this survey. So in terms of implications, GPs and other healthcare professionals might be able to predict who is at high risk of long COVID based on simple clinical risk factors that would be in the patient record and on details of the early phase of their illness. And this might help recovery management and enable earlier referrals to long COVID clinics or particular specialists who can help individuals with particular symptoms. And we need to do further work to understand risks for long COVID after asymptomatic infection, following vaccines, and in children. So I'd like to thank my colleagues who worked with me on this, all at the University of Sussex. And that's the end of my talk, so I'll stop sharing.
Wonderful. Thank you, Elizabeth. We're getting several questions in the Q&A. I'm going to save some of the more general questions for the panel discussion at the end of this, but we've got a couple of minutes. So thought turn to, there's been some specific questions about the Zoe app and how it's used. So from Anonymous, many long COVID patients seem to get better after the initial infection, only to relapse between 2 to 6 weeks later. Does the Zoe app count those who stop reporting, have a temporary gap in their symptoms as they recovered? And if so, could that skew the data or overestimate the proportion of recovered patients? I know you slightly touched on that, but
yeah. So I mean, we as a data scientist using the data at the end decided what the long COVID definition would be, and so we didn't exclude patients on the basis of them not logging any symptoms in the period between the COVID infection and the 12 to 16 week period that we were looking at. We just wanted them to have logged regularly, and then we looked at their symptoms in the 12 to 16 weeks. So I think we would have caught those patients, but it would just, you could adjust the definition of long COVID to make sure you accommodated that presentation and the kind of waxing and waning of the issue. And of course, perhaps it's a limitation that we didn't look beyond sort of 16 weeks of logging. But as I mentioned, you're looking at a very slightly unusual group of people who will log regularly for that length of time. I'm not sure what most people's experience is, but most of the health apps I've downloaded, I've used for about 2-3 weeks and then given up on. So,
yeah,
it's quite an unusual data source, which requires quite a lot of thought about how you interpret what's in it.
Thank you. And just briefly as well, one of the, again, from an anonymous postee, one of the problems of the Zoe app was that many of the symptoms that long COVID patients suffered from, for example, neurological, were not included in the initial symptom list. Therefore, many of us who are experiencing these symptoms did not report these.
That's a problem, and it was certainly a problem in the early days. So we did run an analysis on the early part of of the Zoe collection. So from sort of April through to August of 2020, and that was a real problem because a lot of people reporting long COVID hadn't even had a test, so we didn't know if they'd had the disease or not. That was why we chose this period, kind of August to December in 2020, when a lot of those, that the app had become slightly more stable and a lot of the long COVID features had started to be added. We didn't go beyond sort of mid-December because we knew people were getting vaccinated then, but that hadn't been recorded in the app. So we kind of had this artificial cutoff around mid-December when the vaccine started. So it would be really great to run this out again and looking at vaccinated and unvaccinated people and see if there's a difference.
Great. No, thank you. That's actually answered another question in the chat about the date range as well. So thank you. Okay, so I hope you'll come back and join us for the panel discussion, Elizabeth. So moving on to our second speaker in the session, we switched the order slightly for those who've joined us a bit late, but our next speaker is Danny Altman from Imperial College London, and Danny's going to be talking about immunology of long COVID. Over to you, Danny.
The title I picked was the Immunology of Long COVID. Presumptuous because, as you'll see, we know rather little so far in terms of any certainty about the immunology of long COVID, but I thought it would be helpful to show the direction of travel. Perhaps the other thing to say in parentheses is if the theme for the session is predictors of long COVID, we know perhaps a small amount of predictors of long COVID. We know perhaps a little bit more about correlates and predictors in COVID full stop. So we have a recent study, for example, where we looked at the immunogenetics of susceptibility to COVID. As immunologists, probably our most beloved part of the human genome is the HLA region, the human leukocyte antigen genes that control adaptive immunity. And there are certainly allelic polymorphisms that make you more susceptible or less susceptible to having symptomatic COVID if you're infected. And it remains to be seen whether any of those themes play out in terms of subsequent sequelae of long COVID. If the theme for the next few minutes is carrying on with long COVID, and this picture might be familiar to many of you. It comes from Monique Jackson, who posts her long COVID diary on Instagram, and it shows a picture that will be familiar to many people of Monique trying to convince her GP that she has a thing. And that it's possible to have this thing whether or not you have a formal PCR confirmed diagnosis of COVID-19, and it encompasses really quite a diverse array of symptoms. So for Rosemary Boyd and myself, I guess we'd been hearing about this and seeing this, almost from the beginning of the pandemic reaching this country. In kind of March 2020, and fairly early on we wrote this piece for the BMJ, Decoding the Unknowns in Long COVID, which has kind of stood the test of time. It was a kind of manifesto for what on earth we had to do and what it all meant and where we had to go. If I look at it now, at the time, we didn't know whether this was a story of months or years or lifetimes. And depressingly, we're still none the wiser. Even then, we kind of foresaw a problem in terms of, the way that referrals work in the NHS and the way that money flows in the NHS. That if by nature of the pandemic, so many people simply hadn't accessed PCR confirmation of their diagnosis, not least because at the beginning it wasn't really available, how to get them that access to the care pathway they need. Obviously, the sort of banner headline for the whole day today, the idea that this is an uncharted pathophysiology that needs a bit of brain wattage to sort out, and can't really make do with kind of lazy answers like post-viral syndrome. And like many, I've had many perfectly decent, intelligent clinical colleagues say, well, we all get out of bed occasionally feeling a bit rough, or if you've had a viral illness, you're bound to be under the weather for a while. Getting over the idea that we're not talking about that. We're talking about a fully fledged, large scale, global clinical picture, and that if we're going to grapple with this, we do need better diagnostic tests, and more about that in a moment. And the thing I put in bold here was a sort of not wishing to disrespect any of my colleagues, but a lot of our effort in the beginning, necessarily because of the way that I guess medicine is practiced, a lot of the research effort at the beginning was essentially purely the epidemiological, and the need to identify patterns and count cases before we decided what to do with them. But I think many folks were getting frustrated that at some stage we had to move from the observational to the interventional. It's a mug's game, isn't it, to ever make slides or write papers in the time of COVID that have numbers on them of cases, because the second you give the talk, the numbers are out of date. But suffice to say that if we've settled down on the notion that perhaps 10% of all asymptomatic or symptomatic or severe COVID cases on planet Earth likely have long-term persistent symptoms, then that's an actually huge global burden that we face for we don't know how long in the future. Excuse me. And unless we can make some pretty speedy progress at resolving underlying mechanisms, what hope do we really have of managing patients well and offering some rational therapeutics? So again, by way of a sort of context and scene setting, two of my favorite recent papers from colleagues at University College, just to remind you that the long COVID clinics in the UK are have been rolled out relatively successfully, relatively speedily, relatively variably, simply because of the obvious that this is a work in progress, without treatment guidelines, without diagnostics, without a recognized pathway. And many talented colleagues are just using their knowledge base to put together a package as best they can and refer patients for the best possible management they can. And I know that on social media groups and things, long COVID patients report very variable experiences, and some, I think, manage to access appropriate treatment out of it, and some really don't, which is, I think, both a function of the complexity and heterogeneity of the condition, and the fact that many doctors are very good, but not all are absolute wizards, and can't necessarily conjure up a care package for a new disease process out of thin air. And when I talk about the new disease process, in a way harking back to the previous talk, many studies to look at what's and assemble the pattern of symptoms. This one from Hannah Davis and Athena Akrami and colleagues at University College is the one that many of us know best. The one that kind of put in place a picture of a rather kind of huge array of symptoms, but in perhaps definable clusters, and perhaps with a sort of perceptible picture of relapsing and remitting cycles. So as time has gone by, I think people have had their own ways of looking at long COVID, and I think I've certainly become more more agnostic than I was at the beginning about the idea of it being, perhaps, more than one different mechanism associated with the different manifestations. And I think we shouldn't become too siloed, too tribal in our allocation of favorite mechanisms to the disease process. We just need to look at them in the largest scale and most comprehensive way we can. Right at the beginning, these are some of the ideas that we put down, and I think I still stand by these as being fairly useful roads to go down. The idea that this is a fairly cytopathic virus that will gain entry into any ACE2 in the body, and when it's there, it will cause damage, fibrosis, scarring, and that when one looks at CT scans, one sees evidence of that in many different tissues, and more of that in a moment. The idea that I think has kind of hung on in there, and perhaps with somewhat better evidence as time has gone by, that in at least some examples, another sort of shocker to us, something we never thought that coronaviruses did, the idea that there can be persistent cause of virus infection. I think we especially think about the gut. The reason we think about the gut is because of a kind of triad of evidence of people finding virus in gut biopsies, people amplifying PCR-able sequence from stool samples, and people showing that there are examples that are kind of hard to explain except by a persistent antigen depot of nuclear capsid antibody titers steadily rising with time. And then from other things we'd seen in other viral infections, I think we're keen on looking at the idea that there could be a kind of analogy with the kind of thing that completely other groups of viruses do. Think of the herpes viruses, things like Epstein-Barr virus and cytomegalovirus, where they can really dramatically perturb immune subsets so that immune function starts to be completely different. And then again, more of this in a moment, but the idea that some infections are quite good at setting up a complete de novo bona fide autoimmune response that hasn't been there before, that attacks self tissues, and that can encompass things like prothrombotic autoantibodies, and perhaps another kind of offshoot of this theme, the idea of a kind of endothelial inflammatory or autoimmune response. So I mentioned in that slide the idea of virus infections that can trigger autoimmunity. A lot of our thinking was informed by this. So we do our COVID research in several countries, including both the UK and Brazil. In Brazil, we have two very large cohort studies running across the country. One is called RebraCOVID and looks at COVID and long COVID. And the other is called Replic and looks at another virus infection in Brazil called chikungunya virus. And the reason I bring it up is this: for those of you who aren't that familiar, you can think about it a bit like people in temperate countries think of dengue virus or Zika virus or yellow fever virus. The idea that you have mosquitoes like Aedes aegypti that will and transmit an arbovirus that will typically result in some, malaise and fever and rash. But the thing that's made chikungunya noteworthy and kind of crippling to care systems is the fact that a sizable minority of the people who get infected go on to have a chronic condition which kind of looks like an autoimmune disease. It kind of looks like an autoimmune arthritis. And that almost, long after you've kind of, got used to the idea of the acute infection and another virus infection, it's actually the chronic legacy in autoimmune disease that really devastates people and puts them out of work and puts them out of the economy and puts incredible strain on the hospitals. So you can see where I'm coming from in terms of that analogy. Like a number of the talks represented in this meeting, when NIHR decided to put nearly 20 million into research on the diagnosis and treatment of long COVID, we were one of the long COVID research groups who were funded for a program of work called Immune Analysis of Long COVID to inform rational choices in diagnostic testing and therapeutics. And I just wanted to spend the next few minutes to show you the direction of travel on an actual sort of cohort recruitment that's after much preparation and preamble about to launch really imminently. So you'll have gathered from everything I've said up to now that we think there are immunological mechanisms that underpin this disease process, and we're very much card-carrying human immunologists. So we put together a package deal of all of the analyses that we want to do to try and uncover the mechanism. So if you can picture it, we go out to long COVID patients in the community. We're very keen to speak to the ones who aren't necessarily captured by studies like FOST-COVID, who weren't hospitalized, didn't get that PCR diagnosis, but they know damn well that they had COVID and that they have classic long COVID symptoms. And so they respond to us. We send them a detailed questionnaire so that we can understand their spectrum of symptoms. And then we kind of throw the full immunology toolkit at their blood samples, and going from top to bottom, the top picture is a very kind of fancy flow cytometer. So that's a way of labeling the subsets in amongst the white blood cells into thousands of different subsets and counting them and working out what's up, down, or the same compared to what you would have expected, and therefore what the kind of perturbations are in the immune response. The next one down, that's a speckly picture, is whole proteome autoantibody screening, which is kind of self-explanatory, to really look properly what new aspects of autoimmunity have been turned on. And the next one down, the speckly white wells, is the T cell equivalent of that. So the ability to look at autoimmunity both at the antibody level and at the T cell level. And then the one at the bottom, the kind of RNA heat map, I suppose the fact that when we speak to people with long COVID, everybody at this meeting is very familiar with the array of symptoms, and one of the mystifying a lot, I think, is those kind of changes in allergic profile. People who didn't used to be allergic to things and now are quite profoundly allergic to new things that have never bothered them before. So that's one example of the kind of programmatic changes in immunity that we'd like to get at in more detail. So looking more broadly at what this is all about. So I think that I know that people with long COVID sometimes feel sort of very neglected by the research community and the clinical community, but I can only try and offer some reassurance. I think there's an immense coming together at the moment in a way that I find very exciting. So we're certainly locked in to many different studies, both the post-hospital COVID study, FOST-COVID, our own work over the last few years in publications on healthcare workers with persistent symptoms, CoverScan, which some of you may know, and their MRI analyzed cohorts, the various different NIHR supported projects, our work with ISRIC-4C, our work with the long COVID support groups, Stimulate ICP, who I think are represented here today, and a big subject in its own right, although a somewhat smaller number of patients in total, the question of kids with long COVID, and we're trying to build up more and more links with cohorts, for example, through Evelina. So to give you a taste of what the analysis looks like, the panel in the middle is the top is just a positive control, where you're taking every single protein expressed from the human genome and lighting it up with a positive control. And the panel at the bottom, where you can see much rarer splodges of color, is the pattern that you get of autoantibody light up, where there are particular autoantigens that shouldn't be but are recognized by the immune system. And if you do enough of those on enough people, you can apply fancy maths to it and do a principal component analysis and generate at both the antibody and T cell level a long COVID biosignature that you can both put into diagnostic tests. But obviously it's much more than that, isn't it? Because it's telling you kind of the first bit of the answer of what's gone wrong, and therefore how you might more usefully treat it, and where to go next. So drilling down into a bit of that data, this is part of our collaboration with Raj Banerjee and others at Perspectum, running their cover scan protocol to look by MRI at the relationship between MRI findings and long COVID autoantibody profiles. And in this example, we take people that we've selected from their analysis for MRI lung changes and correlate that with particular patterns of autoantibody. So for us, the next year or so will be devoted to volunteers as we can possibly handle to throw this whole toolkit at them and look in as much detail as we possibly can at what's the diagnostic biosignature, and if we know that, what can we do about it. I tend nowadays to include this picture as a kind of scary picture. It comes from the Glasgow publications about the structure of spike Omicron, to remind you, if anybody needed reminding, that the current beast Omicron is really unspeakably different in so many different ways, isn't it? And in the current situation, in a population where the majority are 2 or 3 days vaccinated, and we have an enormously different we just don't know what the future holds in terms of long COVID in people who've been both vaccinated and Omicron infected. Some of the data suggest a much lower long COVID burden, and yet I'm flummoxed by the fact that the long COVID support groups report, obviously having had an enormous infection wave recently, a lot of new members coming into the membership. So real food for thought there, and for future. So I'll leave it there for our subsequent question session. These are the people in our a lot of the work. On the right of the collaborators, top left is Rosemary Boyd, with whom I run the lab, and everything that we do has been a kind of huge collaboration of many different funders and universities and research teams. So I'll leave it there, but happy to take questions afterwards.
Exceptionally clear and thought-provoking presentation. I think we have questions in the Q&A, but I think we will keep those for the panel discussion towards the end. So if I may, I'll invite our next speaker up to the stage. We have Maxime Taquet from the University of Oxford. Just wait for Maxime to join us. So Maxime's going to be speaking on long COVID from broad to deep phenotyping. Maxime, when you're ready, take it away.
Thank you very much. My title is also a little bit presumptuous, because I'm going to talk a lot about the broad phenotyping and then explain to you or present how we think we can get to the deep phenotyping from there. And so this is essentially the plan for the talk, talking about the result that we've had from large-scale studies, but relatively shallow in their phenotyping, and how we can get to deeper phenotyping and linking that to the broader phenotyping. So the study that I'm going to present to you today is a study that was published in September in PLOS Medicine, and there is a link at the bottom of the screen. It's open access. And the data that we used for this study was electronic health record data from a platform called Trinetics, which gives us access to that to the data. It's made of 62 healthcare organizations in the USA, which are a mix of hospitals, primary care, and specialist facilities. And they cover just over 80 million people in the US, so quite a large proportion of the American population. And both insured and uninsured people are represented in this network. It's quite a rich data set, which gives us access to the patient's diagnosis, their procedures, their medications, etc. And it's accessed in real time, which means that every time you log onto the system, you see that the number of people who have had COVID increases as it does in the general population. And so we can keep some of that description of the data for the panel discussion, but I think it's important to note that this is complementary to the sort of data, for instance, from the Zoe app, in the sense that we don't really rely on people sort of downloading and installing an app. But we do rely on people sort of visiting the healthcare professionals to get anything in their electronic health record data. And so we can discuss these sort of how those two sort of data, as well as other data such as surveys, etc., complement each other. And there were 4 questions that we wanted to answer with this study. The first one was, how common are the symptoms and features of long COVID in the 3 to 6 months after a diagnosis of COVID in the population? We wanted to see whether sex, age, severity of infection, race affected the severity, the risk and the nature of long COVID features. We also wanted to know whether symptoms and features of long COVID tended to co-occur or whether they occurred in isolation. And finally, we wanted to know how specific that was to COVID and how this compares to other respiratory tract infections or influenza in particular. So the approach that we use is quite standard. We do retrospective cohort studies. We compare 2 cohorts. We match them at baseline to make sure that they're not completely different, and making sure that we compare apples to apples. So we match on different confounding factors that we think are important and might relate to both the exposure, so COVID versus influenza, and the outcomes, so long COVID. And then we assess in the 3 to 6 months after the index event, so after COVID-19 or influenza, the rate of outcomes. And these are the main results. So this is the incidence of symptoms in the 3 to 6 months post-infection. So we took a pragmatic, we don't necessarily claim that this is a definition of long COVID. This is a pragmatic approach to capturing aspects of long COVID. I think that's the best way to describe what we've done. Looking at things that can be captured and encoded in patients' electronic health records. So we looked at 9 different features. And what we found is that rates of anxiety and depression was high in the COVID group, as well as rates of pain, abnormal breathing, abdominal symptoms, and quite a few other symptoms as well. And the risk of having, for somebody diagnosed with COVID, the risk of having any one of those diagnoses or codes in the electronic health record in the 3 to 6 months, so excluding the first 3 months after the illness, in the 3 to 6 months after the index infection was 37%. Now, we also looked at what happened in the whole 6 months after the infection, so including the acute phase of the illness. And we found there was that obviously that rate is higher by definition. So 57% of the people diagnosed with COVID went on to have one such code in their electronic health record data. So one long COVID feature recorded in the electronic health records. And by doing a little bit of simple math, we can find that from those 2 numbers, we can find that of those affected in 3 to 6 months, 40% had no symptom recorded in the first 3 months. And so they are not necessarily persisting acute symptoms, is what this suggests. Now, as I said, we also looked at differences between subgroups. So what we did there is we compared groups of patients with COVID. We matched them on everything but one feature. For instance, we took men and women, and we made sure that at baseline they were similar in the comorbidities, for instance, but only sex differed. We also looked at people who were over the age of 45 versus those below the age of 45, and those who had more or less severe infection. What we found is that women were slightly more at risk of having any long COVID feature. Older people were slightly more at risk of having long COVID features, and those severely affected with COVID were much more at risk of having any long COVID feature recorded in their electronic health records. But it did not just affect the frequency, and perhaps more importantly and interestingly, I guess, it affected the type and the nature of symptoms. So what you see here are spider plots showing the relative risk in male versus female. So green means more likely in female, red means more likely in male. And what you see is that men were more likely to have cognitive problems and abnormal breathing, but less likely to have headaches, abdominal symptoms, anxiety, and depression. Similarly, older people were more likely, as expected, I suppose, to have cognitive problems and abnormal breathing, but again, less likely to have headaches, abdominal symptoms, and anxiety and depression. And then more severely affected, as measured by the requirement to be hospitalized at the time of COVID, or indeed being admitted to an intensive care unit, were much more at risk to have almost all of the features of long COVID, but headaches and myalgia, which might be significant. Now we looked at whether long COVID features tended to co-occur, so occurred together, as opposed to occurred in isolation in a single individual. And so we represent that as a network. And what you see is that the darker the line between two symptoms, the more likely they are to co-occur in the same individual compared to occur in isolation. And I think the main finding there is that the probability for two symptoms to co-occur increases as time from the index infection increases. What that means is that early on after having an infection, the risk of those symptoms is quite high. But when somebody or a patient experiences one of those symptoms, it tends to be in isolation. Much more so, and relatively speaking, than if they were to experience them later on after their infection, say a few months after the infection, in which case they're much more likely to experience them in combination, so to have a cluster of symptoms. Now, how did that compare to the flu? Well, there is some specificity to COVID-19. So people affected with COVID-19 were 50% more likely to have symptoms of long COVID compared to the flu. And you can look at that in two different ways. And depending on what newspaper you read, you might have seen those results reported in different ways. So you can say, well, it's specific to COVID, and COVID is not the flu, and that certainly is correct. It's much more likely to develop a long COVID feature after COVID compared to the flu. However, it's not 10 times more likely. And as some newspaper, including and media, including the BBC, have reported, we don't talk about long flu, but we might have to. And I'm not saying that this necessarily suggests and warrant this conclusion, but it certainly is a possibility. So the conclusion from this study is that over 1/3 of people were diagnosed with at least one long COVID symptom between 3 and 6 months after the illness. Severity of illness, age, and sex affected the incidence and profile of long COVID symptoms. I didn't present the results about race because there was virtually no difference between races in the findings, and you can find that in the paper. And similar symptoms were seen in people after the flu, but they occurred and co-occurred less commonly. Now, what about vaccinated individuals with breakthrough infections? So this is a preprint, so it's should be mindful that this is not peer-reviewed yet. But we compared people who were vaccinated prior to having COVID compared to those who were not vaccinated at the time of COVID, and we took care of trying as much as we could to make sure that they were not anti-vax people, because there might be some health behaviors associated with that attribute, and we did that by making sure that they had received the vaccine for something else before. And what we found is that, broadly speaking, there was no difference in the rate of long COVID features as defined in our previous study between those who were vaccinated compared to those who were not vaccinated. And you can see that on the right-hand side. So we looked at a wealth of outcomes, not just long COVID, but you can see the long COVID one being circled there. And the confidence interval is quite narrow, as you would expect, because those are not rare outcomes, but very much centered at one. Does that mean that being vaccinated is not protective against long COVID? Well, against long COVID, absolutely not, because the best way to prevent long COVID is to prevent COVID in the first place, and that's important to keep in mind. But if you're unlucky enough to have COVID, despite being vaccinated, what this data suggests is that you're just as likely to have a long COVID feature. That doesn't mean that it's the case for all long COVID features. And as you can see, some of the long COVID features are actually significantly less prevalent after or incident after being vaccinated, if you were vaccinated against COVID, and that includes myalgia and fatigue. So it's important to keep in mind the limitation of this sort of studies, and there are known unknowns and caveats with that sort of study. The first thing is that we don't know the severity of the symptoms, nor if patients recovered. It's very difficult to get to that level of detail with electronic health record data, and that's why we need prospective cohort studies as well as surveys. Other patients may have similar symptoms but have not had them recorded, because we rely on things recorded in the electronic health record data, and if it's not recorded, we don't capture it. The behavior of clinicians and patients may affect if and how symptoms are being recorded, and that's also important to keep in mind when we interpret those findings. It's unclear if the results apply to people who had asymptomatic COVID-19 infection, or to children under 10, or to people in other healthcare settings, because those were not part of the population that we looked at. And the data say nothing about the causes or treatment of long COVID symptoms, and that must be a priority for research, among other things. And this is what we try to focus on, at least for one long COVID feature, which is the cognitive deficit, or as is commonly called, the brain fog. And this is what I want to talk to you about in the next few minutes of this talk. So how do we move from the broad big data phenotyping to something finer grain and much deeper in terms of the level of understanding that we get in terms of the mechanisms involved? And this is a study that's been funded, that just started at the beginning of this month, which is called CFOG. And the idea is to move from broad phenotyping to deep phenotyping. And the way we plan to do that is, I guess we started doing it, is by having a relatively agnostic set of hypotheses that we think might be explainable mechanisms for brain fog post-COVID. And we filter those hypotheses through electronic health record data. So in a way, we think, well, if there is one mechanism at play, it makes prediction about what we might observe in electronic health record data. And so if we do observe it, then that hypothesis survives. And if it doesn't, if it's not being observed in the electronic health record data, then that hypothesis is sort of being sidelined. And we do that by combining Trinetics network, which we have used in our previous study, and OpenSafely, which is another electronic health record network, which is being used in the UK. To have sort of a discovery science approach where we can generate hypotheses with one and then test them with the other. And then we use data from the FOSP COVID study, which has been mentioned in previous talks, which is a prospective cohort study of hospitalized patients with COVID, about 2,000 of them. And we already have quite a bit of phenotyping as part of this study, and we augmented specifically for brain fog by looking at specific imaging biomarkers as well as cognitive phenotyping. And then we test the hypothesis that we've selected as part of the discovery science step using this sort of these deeper phenotypes. Now, this is not a sort of data science completely blind approach to finding out the mechanisms. There's quite a lot of domain knowledge, as it's sometimes called in the machine learning literature. So there's a lot of human intelligence, not just artificial intelligence, is what I'm getting at. Because we need to, well, we need to have a sensible way of defining the hypothesis in the first place, but we also need to have some human intelligence and domain knowledge to know how sort of they translate from the electronic health records level to the deeper phenotype level. And so this is what we started doing, and we're very excited to see whether that's going to give us some answers to pressing questions. And with that, I'd like to thank you very much.
So I'd like to call all of the speakers back to the main stage, and for the panel discussion section of this session. And please do keep your questions coming in. I'll be monitoring the Q&A. I can see some questions coming in for specific speakers, but if you've got questions for the whole panel, the panel as a whole as well, that'll be excellent. Thank you. Good. So, of the risk factors that keep coming up time and again, we see female sex, but as an observation, I mean, the increased risk varies quite dramatically between the different reports. I wondered if the speakers, perhaps Max and Elizabeth in particular, wanted to comment on that. Is that the nature of the way the data's been collected across the different studies?
Yeah, I'm happy.
You want to start? Yeah, go ahead.
Yeah, shall I start? I would be interested to hear from Danny whether he thinks it's something hormonal, because in the Zoe app data we found that it was true for younger women, but in the over 70s, actually men were more at risk. So I just wondered, one hypothesis is something to do with women's hormones. The other thing I was really interested in Maxime's data is, of course, that electronic health records data is filtered through the clinicians' biases and preconceptions about illness. So I wondered also, especially with the different symptom profiles in men and women, there is a kind of inherent bias to diagnose women with anxiety and depression, I think, when they come in with unexplained symptoms, and that was true sort of in the symptom profiles that you presented, Max. So I don't know whether either of you have some comment on that.
Yes, shall I go next?
Yeah, go ahead.
No, just to kind of state some of the obvious in response to that. That any sort of gender skewing, there's a temptation, isn't there, to trivialize it, and in parts of the press to trivialize it and say, oh, it's ascertainment bias, because for a kind of diagnosis like this, women are more likely to be in touch with those feelings and report them on social media websites and things. And for somebody from my kind of background, that couldn't be further from the truth, because the second you see something like this and you're wondering about an autoimmune etiology, the first thought that comes into your head is that autoimmune diseases are massively skewed, very, very commonly, to female gender, and that there are rather good immunological explanations for that in terms of hormonal differences and how they program immune subsets, and particularly how they program regulatory T cells, so the sort of policing cells that are meant to dampen excessive immune responses. So if we can only kind of get our act together and do all the work, plenty of hypotheses to look at that would explain very rationally why you might have some some skewed distribution of these symptoms.
I very much agree with what's been said, and I think the short answer is that we don't know why. It might well be biases in terms of clinician biases. It might be that women or men might be more or less likely to approach a clinician for a specific symptom. They might be more or less likely to download an app to report that sort of symptoms. They might be more or less likely to report the symptoms when they have it. And there might be some biological mechanisms. Absolutely. I think that's very important as well. And so I think the short answer is we don't know yet. And it's a very important question, obviously.
Great. No, thank you. And there was a question from Mena Hart in the chat along the same lines. So thank you all for addressing that. I mean, the other thing we see is hospital admission associated with greater incidence. I mean, obviously we don't know, but is this, do you think, reflecting the initial viral load or the severity of the initial illness, or is there some interaction with the sort of established phenotype of post-ICU fatigue and potentially sort of bed rest, detraining symptoms as well coming into play, particularly when we talk about fatigue?
Can I maybe chip in first? Yeah,
please do, Danny.
Yeah, again, that I think it just, to me, that the very question kind of exemplifies the conundrum we all have. Yeah, that you'd want to be able to kind of draw a precise correlative line, wouldn't you, where you'd say more severe acute disease equals more virus on board for longer equals more viral damage equals more persistent symptoms. And sometimes, there are elements to long COVID that are like that, and that comes out in the FOSP-COVID first two papers. And yet, long COVID clinics are full of people who had asymptomatic acute infections. So whatever that correlation is, it's not a very good straight line. And it's far more mystifying and mystical than any of us are owning up to.
I want to agree with that as well. And as I've shown on one of the slides, the profile of symptoms is different. So even though overall the risk of having any long COVID feature is different, the sort of symptoms is quite it can be quite different as well. And headaches, as I said, is more common after if you've not been hospitalized compared to if you have been hospitalized with COVID. But the opposite is true for brain fog, for instance. So it's very important to keep that in mind and to not just think, well, a sort of simple linear explanation, as Danny has also clearly highlighted.
Yeah, I agree with all of that, and I think this deconditioning argument is a really difficult one. I think a lot of patients have found it very difficult, especially as other chronic fatigue syndromes, or ME, can have this symptom called post-exertional symptom exacerbation, where when people really, try to get up and go and take exercise, then they're set back for weeks. And long COVID patients report that too, in some cases. Our study did find that the severity of initial symptoms was highly predictive of long COVID, with worse symptoms predicting a higher risk of long COVID. But of course, as I said, we did also find some asymptomatic patients also had long COVID. So yeah, as Danny said, it's not a linear relationship.
No, indeed. It's a question that was posted by Rachel Meach initially to Elizabeth, but perhaps all of you would like to address this. And the question was, does your study consider people who have been reinfected with COVID, and how does this alter the data? Perhaps so I can put it to Elizabeth first, and then
we didn't consider that, and back in I think that would have been quite a low proportion of people back in August to December 2020. It would certainly be an interesting thing to look at with new data now. I think that should certainly be looked at, especially with Omicron having such a high rate of reinfection compared to other strains.
Maxine, were you able to look at reinfection?
Yes, I maybe want to highlight, if anybody is working with the same sort of data, that reinfection is not something that people should look at with electronic health records, and that's because there's recoding, which is not the same as reinfection. So you see your GP, you've got COVID coded in your electronic health records, then you go to a hospital for something different, and you're being asked if you had COVID. Oh yes, 2 months ago, and you get it coded again. And so that's why we've been very careful when we did those studies to look at the first instance of COVID being encoded in people's electronic health record data, and we shouldn't look at recurrence unless there is a code for recurrence that emerges in ICD-10, but at the moment there isn't, and so we will not look at that. But it is a very important question, obviously, but not one we can answer with EHR data.
Danny, do you have any comments on reinfection?
Well, no, just that, like everything else, it's such a kind of rapid work in progress, isn't it? So certainly in our analysis, there's so much more to get to grips with than when we wrote down our first documents a year ago, in terms of trying to decode infection versus reinfection versus multiple reinfections versus the presence of vaccines versus people who were in the first wave compared to the alpha wave, compared to the delta wave, compared to the Omicron wave. And that's a level of granularity that we never thought we'd have to grapple with, and we're trying to now. And there's stuff to be found out about it.
And there was a specific question to Elizabeth about your findings regarding vitamins. Would you like to comment further, Elizabeth? I think you said no vitamins and vitamin D supplement were both risk factors.
Yeah, it was quite difficult to interpret. So it looked as if people who didn't take vitamins were at lower risk of long COVID in our model, but that vitamin D supplementation was potentially protective. But the way logistic regression works and the way that different variables get put together, you do sometimes get slightly spurious results in a multivariable model. So I wouldn't like to suggest that that people should start taking vitamins or stop taking vitamins as a result of our finding. And also that might be a proxy for other health behaviors or other underlying conditions. That's another hypothesis.
So there's been some questions about the viral persistence versus autoimmunity hypotheses. And Danny, is the data out there about from immunosuppressed patients or patients on immunosuppressants, and how that is influencing long COVID symptoms and reporting?
Yeah, that's a really interesting question, isn't it? So as you said, I'm struggling to think of any really good, convincing data sets I've seen on that. I don't think I have seen them yet. Then if anybody else has, clearly, that will be informative. Everything in COVID times is so complex, isn't it? Because a lot of the people immune suppressants are vulnerable people who've been COVID shielded, and I think do have a lot less long COVID for very good reasons. So it's just tricky.
Yeah. Did either of you, Max or Elizabeth, have any comments along those lines? I suppose no. Okay. There's another question in the chat. Was there? I think again this was perhaps to Elizabeth, but maybe also to Max. Was there a way to differentiate between post-COVID symptoms from a previous condition, and could that be a reason for limited activity and comorbidity being risk factors? Was the question. I mean, in your studies, are you able to distinguish between prolonged symptoms following a different illness?
So we tried to control for this by subtracting from the symptoms reported after COVID, any symptoms which had been reported regularly prior to the COVID infection. So we just kept the kind of symptom score that was novel and new as a result of the COVID infection. And that was our way of trying to identify that somebody was in worse health, basically, in that longer period after COVID. So yeah, we basically were looking at the sort of differential in between symptoms before and after the infection.
And
I guess we did something quite complementary to that, but comparing a cohort of people who had COVID compared to those who had influenza, correcting or adjusting for 70 different risk factors for COVID and for severe COVID, sort of addresses that, because you would at least in part, because you would have to then believe that those would be symptoms that occur only in people who have COVID and could have had influenza, but they had COVID, but they had those symptoms before COVID, and that becomes very intricate to try and explain away. The other thing that we did is obviously looking at the first 3 months compared to the next 3 months, and we see that those are people who did not have symptoms recorded in the first 3 months. Now, obviously, if they had those symptoms before COVID, it would probably be just as likely, if not more likely, that they would report them in the first 3 months compared to the next 3 months, and that's not what we see. So we don't think that that's an explanation.
I mean, of course, it's possible that their symptoms 12 weeks after COVID could be a result of some other illness that wasn't actually at all related to the COVID infection, but we hope that would only have a very small effect on our results.
One thing you hinted at in your presentation, Max, was the similar symptoms may appear, long flu, essentially, following influenza. And of course, we almost skipped an entire influenza season when we were all self-isolating or staying at home in the end of 2020. Do you predict that we're going to see an emergence of people who have been infected with Omicron, perhaps, and flu in the same season? And do we think there'll be an interaction between these infections?
I guess there might well be. I think what this result highlighted, and we need to be quite cautious about how we interpret it and not to over-interpret it, because we didn't have a third control group who had neither influenza nor COVID. And that's the important thing, which actually makes it very clear that we can't answer that question. But I think if it does stimulate research into what might happen after a viral infection, as I know that a lot of research has been happening before, it might not have been in the spotlight, but if this is a sort of an incentive to go back into that and maybe look at it with the same sort of multidisciplinary and breadth of investigation as we've done for long COVID, that's probably very good for those patients. So if this is one conclusion, I'd be happy if this is the conclusion taken away from that and other papers.
There was a specific question, I think, this was during Danny's talk about, I think your studies in Brazil looking at chikungunya and COVID what was the rate of co-infection in the study population whether subjects were infected with both viruses?
So obviously, Brazil is a very, very big place all the time. So they've had such a bad ride with COVID. Quite a lot of that time has been quite a quiet time for chikungunya, and the last 3 or 4 months, particularly in some places like Recife, there's been an enormous burst of people co-infected by COVID and chikungunya, and so we're trying to start analysing those now and trying to understand whether there's a greater risk of kind of a synergistic risk of chronic disease.
Yeah, thank you. Quickly going through the chat. So there was a question about from Rachel Jones. Many of the long COVID symptoms overlap with menopause symptoms, and of course, women in the menopausal age are the most likely to get long COVID. Do you think there's a shared pathophysiology, or has anyone checked hormones in women with long COVID to see if they've been pushed into menopause? I don't know if anybody would like to comment on that.
It is an interesting suggestion. I can't say that we have looked at it at all. So,
okay.
Same here.
Yeah, and I'm aware of enormous interest in the subject, and could offer immunological hypotheses till the cows come home. But I guess we all just have to do the work.
Yeah, good. We were hearing quite a bit this morning, and quite a powerful testimony at the start of the day from Anusha Edwards about which really illustrated the intra-individual variability, the day-to-day fluctuation in symptoms. And is there anything in any of the data presented, or in your analysis of the autoimmune aspects of the condition, Danny, that might help to try to explain that, or could you speculate around what might cause such a fluctuation in symptoms in individuals with long COVID?
I'm not sure if I can sort of constructively speculate at the moment based on any data we've got so far, but just that it really is kind of grist to our mill as immunologists and as students of autoimmunity, because so many diseases out there where we've struggled over the decades to understand flares and remissions, or relapsing and remitting cycles, or whatever you want to call it, in diseases from MS to lupus. And I think now we've really got the opportunity and the incentive to really, and the technology to nail that down, because obviously immune controls and immune subsets are very fluid, dynamic things, and we've got the toolkit now to look at that properly, and I think probably get some answers.
Yep. Max, Elizabeth, were you able to track variability day to day in your subjects?
So the problem we had, of course, was logging versus not logging. So if somebody chose not to log for a certain period of time, we didn't know if it was just because they didn't want to, or because they had no symptoms to log in that period. So yeah, I think we did find some variability of symptoms, but we didn't model that or try and predict it in any way.
Level of temporal granularity in our data, apart from, as I said, but the first 3 months and the next 3 months, where we've seen that there is at least if at least not sort of persistent of symptoms from the acute illness all the way to the longer phase of the illness. So, but we didn't have anything more granular than that.
Thank you.
But that variability of symptoms has been reported by long COVID patients since the beginning of the pandemic, since the first earliest reports, and a lot of reports of people feeling better for a good portion of time and trying to get back to normal activities, and then being set back again. So, I hope that there will be plenty of groups looking into that.
Right. Got a quite technical question from Maha Alanazi. I think to Danny, can you talk about the subsets of cells in immunoprofiling in long COVID? If we were to do flow, what do you recommend we go after?
Oh, how many days have you got? Yeah, no. So I'd be reluctant to come into it with any, proposing any kind of a priori assumptions of what you should measure. And to me, it's like all of the immunology of long COVID. I saw some other examples in the chat where there are people who've read about or seen studies or have favored hypotheses of particular subsets or particular autoantibodies. And for me, the whole point is to be as comprehensive and as open-ended as possible and go in with no prior assumptions and just measure everything, because I think that's the best way to find stuff. So I think it'd be foolish to send people saying, why didn't you get yourself a test to look at your Tregs or your CD4s or your, T effector memory or anything. Just, look at everything.
Yeah. And question from an anonymous: if you looked at the autoimmune responses in patients infected with COVID and vaccinated versus vaccinated only?
It's certainly part of our study, yes. So we don't know the answers yet, but that's absolutely part of the comparison.
Mm-hmm. And in terms of the different vaccines, do they seem are there different protective effects across the different vaccines that have been available? I mean, there was some reports early that if you mixed vaccines, you'd be protected against COVID infection. But is that protective against long COVID in anybody's experience?
So quite good studies out there now. So I think Maxime was the one who said that the best COVID is to prevent COVID, and obviously all of the vaccines that we have on planet Earth pretty well are variably good at doing that. So if you want to keep down vaccinated and boosted, and get rid of the infections, there's been quite good. There's a preprint doing the rounds from Israel about impact of vaccination on long COVID. But thornier question has been in prior infected established long COVID, whether subsequent vaccination modulates it, and that's been much trickier, and I think hard to get to the bottom line, because to my mind it's maybe 20% showing improvement, 20% showing exacerbation, and the rest not much change. But don't quote me on that.
Yeah, I think the ONS released their report recently last week, showing that in vaccinated individuals, if they had a breakthrough infection, they were 50% less likely to get long COVID. Yeah. But I don't know that looked at type of vaccination, which vaccine those people had, and that was after 2 vaccines rather than also looking at the booster effect, which seems to be quite strong. So, yeah, there does seem to be an effect. And they also reviewed the literature on improvements in people who had got long COVID and then got vaccinated. But as Danny says, it's not very clear at the moment. A mild improvement in some people, I think, is as far as they went.
Yeah. Our study does not show an improvement apart from the improvement through limiting COVID on long COVID. That is, if you're unlucky to have COVID despite being vaccinated, you're just as likely to have long COVID. I think and I agree that there's been other studies showing the opposite pattern, and that shows the difficulty of answering that question, and the importance of looking at those papers and one by one and critically appraise them, because there's a lot of potential. I mean, unless there was a randomized controlled trial, of which there isn't. There is loads of sources of bias. One of them, as I said, is the anti-vax bias. You compare people who are not getting the vaccine for a reason, because everybody had access to the vaccine, and you compare them to people who were vaccinated for a reason. And I think we need to be careful about how we interpret those findings. I think this is an open question, despite quite a few papers now, most of them in preprint, trying to address that question in a meaningful way.
Yeah, and of course, the historic data may have compared people who were vaccinated at the start of the vaccination program to those who weren't. In which case, then you're not, you're comparing in the UK older people to younger people. And if there's this hormonal hypothesis with women that they, younger women are more at risk of long COVID, then you're going to see lower rates of long COVID potentially in the older people, but then they might have more severe disease, so you might see higher rates. So yeah, it's very complex to tease out the vaccination effect.
Thank you. One, speaking of outstanding questions, one thing you hinted at in your talk, Max, was the how little we know about long COVID in children. Of course, children are less, or seem to be less susceptible to getting a severe form of the initial illness. But I wonder if the speakers would like to comment on what is currently known about long COVID in children, and to speculate how big a burden that may become. Maybe Max, you could.
Well, we had data on 10 to 21-year-old, which respectively was a terrible idea, because we should have looked at 10 to 18, or actually 0 to 18, which we didn't. But if we extrapolate from that and we say, well, those are basically teenagers and very young adults, the risk of long COVID is very much there. And again, with a slightly different profile of symptoms, you don't see as much brain fog, bearing in mind that this is not relative to their peers who do not have COVID. This is compared to all the people. So, but they have higher rates of brain fog, for instance, compared to having had the flu. They have higher rates of depression compared to those who have had the flu. So it seems very much, according to our data and other data who've now looked specifically at children, that the risk of long COVID in children is very much there. And so I think this is areas of concern, obviously, given the stage of development that those children are at.
Yeah, I just add a few words to that. Again, if you either spend time mixing with pediatric COVID clinicians or with support groups like long COVID kids, for my taste, the bullet points are that, luckily, considering the enormous infection rates we've had in primary and secondary schools during Delta and Omicron, long COVID or any persistent symptoms are much rarer than they are in adults. And yet, nevertheless, because of the enormous wave we've had, there are plenty of kids with quite severe long COVID. It looks phenotypically slightly distinct to adult long COVID, but it's a thing, and it's a very large thing considering the caseload we've had. It's just less apparent than in the adults, and it's it's a devastating thing for those children.
And potentially a lifelong
who knows? Yeah.
Question: Do the speakers have any thoughts on potential treatments if long COVID is autoimmune?
Well, I'll just chip in with one sentence that again, as an immunologist, I think that molecular immunology has been one of the great victories of molecular medicine of the last few decades. And the shelf of goodies is enormous and growing all the time. So once we've got a better clue about what's going on, I think there's quite a lot on offer.
Okay. We're just coming to the end of our session, but perhaps I'll pick up on one more thing before we close. I mean, some of Elizabeth's data showed clustering of the different symptoms, and I just wanted to pick up on that again alongside, your comments, Danny, that we should be viewing this as a single syndrome as well. I don't necessarily see a conflict in the two statements. Of course, you are seeing different manifestations of the disease, but I just wanted to, in the last minute or so, get the different speakers' thoughts on that observation that whilst the symptoms may cluster, there is a single condition here. Elizabeth, perhaps would like to comment.
Yeah, it's difficult to interpret, clinically what we found, because obviously we didn't find that robust result through the different methods of clustering the data. But I'd like to hear Danny's view really on whether he thinks that a virus and the autoimmune response potentially can manifest just in different parts of the body, given the same infection. I would think that was probably what was going on.
Yeah, I'd add, my 2 pence. The metaphor that I always use. Think of lupus. Single molecular pathogenesis, so many different manifestations. So in the age of personalized medicine, we're used to the kind of apparent conflict between lumpers and slicers, and there's benefit from both.
Mm-hmm.
Max, any closing thoughts?
Well, I think one of the conclusion from this panel discussion and everything we've heard before is that there's still some unknowns. And I guess if I can close by saying that if there's any young researcher listening to this, and I think there's plenty more to be discovered about long COVID, and it's a very exciting and important field of research. So yeah.
Thank you to you all for a really stimulating discussion and for taking the questions from the audience. Thank you, of course, for your excellent talks, and look forward to discussing some of the future research topics in our session tomorrow. So thank you to everybody who's listening. We now have a short break. Join us again at 3:30 for when we're going to be discussing the impact of COVID on elite athletes and military perspective. Thank you very much.
Thank you.